Hi, my name is Atif Darwish, Professor of OBGYN at University Egypt. In this talk, we would like to address a very important, challenging topic of thin endometrium during transvaginal examination of infertility cases. The endometrium is composed of two main layers, the zona compacta and zona spongiosa, forming zona functionalis, which is subjected to monthly shedding with the menstruation because it is supplied by the spiral artery, which is coiled artery and usually sloughs with the menstruation, and the basal layer, which is zona bisalis, which is supplied by the straight artery, and it is responsible for regeneration of the functional zone above it. So in the early proliferative phase of the menstruation, we can see the spongy layer, compact layer are growing, proliferating, and in the second half of the cycle, which is secretory phase, the glands are too many and the tortuous, so the endometrium will be thick. So if we are doing ultrasonography for a case during proliferative phase, we should expect that the endometrium is little bit thin and hypoechogenic. If compared to the second half cycle, the endometrium is thick and hyper. Perfect evaluation of the endometrium by transvaginal sonography depends on the menstrual day of this patient. If we examine the patient at the menstruation or just at the end of menstruation, you may see fluid inside the endometrial cavity, which is a residual menstruation, and the endometrium is very thin at that time. Thereafter, the endometrium is very thin, simple, single strip, but hyperechogenic due to the presence of zona bisalis only. After proliferation, the zona bisalis is lined by zona functionalis, which is zona compacta and spongiosa, and these two layers are forming the functional endometrium. So the endometrium starts to become more thick, and these functional layers with increased fluid, increased blood, will be hypoechogenic, surrounded by hyperechogenic basal layer, which is zona bisalis. Pre-ovulatory, the endometrium will take a three line or triple line pattern, which means zona bisalis, zona functionalis together. After ovulation, the triple line appearance disappears and the endometrium is replaced by hyperechogenic homogeneous appearance, which is the secretory endometrium in the luteal phase. So as I told you, in the early proliferative phase, endometrium is single layer, thin, hyperechogenic strip due to zona bisalis. The trilaminar layer, pre-ovulatory trilaminar appearance, is formed by the zona bisalis, which is echogenic, forming the two lines of the trilaminar appearance of the endometrium, in between the hypoechogenic functional layer, zona functionalis, and we can see another line, which is the third line, which is echogenic line, in between the two lines, and dividing the zona functionalis into two parts. From where it comes? It comes from reflection of the endometrium. It is not a real layer. We have only zona bisalis and zona functionalis, and the third line represents division of the zona functionalis by the reflection of the endometrium at the central interface. After ovulation, the secretory endometrium appears as thick hyperechogenic layer with disappearance of the trilaminar appearance due to edema and isoechogenic appearance of this basal layer. So during transvaginal sonography, we should comment on the thickness and echogenicity as well. The Canadian Fertility and Andrology Society 2019 mentions that the endometrium should be measured transvaginally in the sagittal plane at the thickest portion near the fundus, with strong evidence for this. Some factors can affect the measurement of the endometrial thickness and echogenicity as well, like fibroids, adenomyosis, polypi, uterine orientation, body habits, previous surgeries, uterine contractions, ultrasound machine quality, inter-observer or intra-observer variability, and patient intolerance. Some authors mention that during examination the uterus is subjected to natural contractions, and these contractions can lead to change of the endometrial thickness of up to 4 millimeters. So we have to consider uterine contractions during examination. But unfortunately, these studies are not well supported with weak evidence in the practice. To sum up, the endometrium is subjected to cyclic changes. If we examine the patient during menstruation or just after menstruation, the endometrial thickness is very minimal. It should be less than 4 millimeter. In the early proliferative phase, it grows up to 7 millimeter. Pre-ovulatory, trilaminar, up to 11 millimeters. Secretory phase up to 16 millimeter. And if we examine a patient just after curettage or evacuation or spontaneous abortion, it should be less than 5 millimeters. The radiologist improved our orientation about the endometrium by using MRI to evaluate the endometrium and the adjacent myometrium. On T2, the normal endometrium appears as homogeneous, hyper-intense, regardless the phase of the menstrual cycle, surrounded by hypo-intense junctional zone, which is a part of the myometrium. And this is very important for diagnosing adenomyosis, early diagnosis of adenomyosis by MRI. The hypo-intense is due to decreased vasculature and water content in the myometrium, while hyper-intense endometrium is due to increased vascularity and water content. So the endometrium can be classified as M, which is just menstrual endometrium, A, just postmenstrual, B, early follicular phase, C, pre-ovulatory trilaminar endometrium, and D, in the luteal phase. During transvaginal sonography of any case of infertility, don't forget to comment on the endometrial thickness as well as the pattern. Why the endometrium is very important for us in infertility cases? Simply because the endometrium is a site for implantation. So if we evaluate the endometrium well, this means that the possibility of implantation is high. And in such a case, the endometrium is called a receptive endometrium, which means it's ready for implantation of the blastocysts. The best site, the best time for endometrium to be receptive is 6 to 10 days post-ovulation, and at that time the endometrium is ready for implantation, and it's called implantation window, which is the period at ready for implantation, and the endometrium is called a receptive endometrium. So what is the relationship of the endometrial thickness with the receptivity? The endometrial thickness is not synonymous to receptivity. It is just a marker of endometrial receptivity and a prognostic factor, which means that we don't have to rely on endometrial thickness in all cases in 100%. No, we can use endometrial thickness as a parameter, an indicator of endometrial receptivity and prognostic factor. But if you say to your patient you have a thin endometrium, you don't have a chance to have pregnancy, no, this is not good, because some reports of thin endometrium with good pregnancy rate and normal endometrium without pregnancy rate. So the endometrial thickness is a marker of receptivity and a prognostic factor. There is no clear consensus on what's too thin, what's too thick. The optimal thickness of the endometrium at the time of ovulation, pre-ovulatory, should be more than 8 millimeter. If it is less than 8 millimeter, this means less possibility of pregnancy. And in this figure, you can see that at that time of the pre-ovulatory time, the endometrium around 9 to 10 millimeter is average. We read the term of refractory endometrium, which means endometrium less than 7 millimeter, pre-ovulatory 7 millimeter, and the definite definition of thin endometrium is variable between publications, but most of them use the 7 millimeter as a parameter. If it is less than or equals 7 millimeter, it's thin endometrium. Some authors use if it is less than 8 millimeter. In all cases of thin endometrium, there is association with decreased implantation. Recommendation mentions that the incidence of thin endometrium is variable in between 2.4 to up to 66% in retrospective and prospective observational studies, and most of the studies did not include cancelled cycles, so the actual incidence of thin endometrium is not clear. What is the cause of thin endometrium? Why some women have thin endometrium? Actually, the thin endometrium is due to decreased normal endometrial growth, and decreased growth may be due to many factors. Number one, congenital hypoestrogenism in cases of genital ridge anomalies, ovarian poor development, uterine poor development, Mullerian duct anomalies in the form of hypoplasia, in the form of septate uterus, biconate uterus, and so on. So this is a congenital cause of thin endometrium. Inflammatory cause may be endometritis or PID. Iatrogenic is due to drugs like prolonged use of COCs or column-citrate use, in addition to surgical causes like polypectomy, hysteroscopic myomectomy, laparoscopic myomectomy, repeated curettage, and PID, in addition to surgical interventions, can lead to intrauterine adhesions, which is another cause of thin endometrium. And don't forget to put hypoestrogenism as a cause of thin endometrium in your mind. Hypoestrogenism is a basic cause because estrogen is the hormone of growth of the endometrium. So the mechanisms of formation of thin endometrium: endometrial resistance to circulatory estrogen, reduced blood flow to the endometrium, overexposure to testosterone, or permanent damage of the basal layer of the endometrium. Now, can we use column-citrate or tamoxifen for induction ovulation? Both are effective regarding ovulation rate, but the pregnancy rate is less with column-citrate due to its deleterious effect on the cervical mucus and endometrial receptivity, which means endometrial thickness, as an indirect indicator, as I told you, due to its anti-estrogenic effect on the endometrium. On the other hand, tamoxifen is a selective estrogen receptor modulator that has a weak estrogenic effect, so its effect on the endometrium is not bad as column-citrate. Now, the patient with thin endometrium, what is the complaint of this patient? Usually infertility, or discovered during transvaginal sonography, but they may have some menstrual abnormalities like hypomenorrhea, irregular and painful menstruation, or abnormal and irregular menstruation. In this algorithm, we can summarize the impact of thin endometrium on the patient's fertility. We have three groups of patients. Patients is subjected to ovarian stimulation cycle without any assisted reproductive techniques. In those cases, if you see thin endometrium, don't inform the patient that your pregnancy rate is low, because the evidence found that there is no impact on pregnancy outcome in this group. No need to change stimulation protocol, no need to use adjuvants to improve the pregnancy rate, because if you use adjuvants, if you change stimulation protocol, this is not associated with improved pregnancy rate, and the evidence for doing these techniques or procedures is weak. On the other hand, if we have a patient subjected to fresh or frozen IVF cycles, we should inform those patients that if they have endometrial thickness less than 8 millimeter, that they have a negative impact on pregnancy rate and live birth rate. And this is very important during counseling of a patient with thin endometrium subjected to fresh or frozen IVF cycles. And this is a great evidence or strong evidence. But in such a case, the patients ask you, can you make adjuvant lines of treatment like freeze-all, like use of aspirin, sildenafil, estradiol, intrauterine infusion of granulocyte colony stimulation factor, pentoxifillin, HCG, GnRH agonist, PRP, or stem cells? You answer that adding these adjuvants to lines of treatment has poor, weak evidence to support, to increase pregnancy rate and live birth rate. The strongest evidence that you have a less chance of pregnancy rate and live birth rate. Now the question, can we change the protocol of induction to natural cycle, and can we use hormonal replacement? Also weak evidence supporting these protocols. The strongest evidence in this era is that counseling of our patients with thin endometrium less than 8 millimeter is associated with negative impact on pregnancy rate and live birth rate in fresh and frozen IVF cycles. Now the patients ask you, can you provide a line of treatment for this thin endometrium? Yes, we can offer natural lines of treatment like some herbal and natural supplements to regulate estrogen levels, some regular daily exercise advice for your patient to increase blood flow to the uterus, some fertility massage also to increase blood supply to the uterus and endometrium, usage of castor oil packs and acupunctures. All these are natural lines of treatment to improve the vasculature of the endometrium and the uterus as a whole. But if we go in depth in the management, we should treat the case according to the cause. It should be cause related. The aim of treatment of thin endometrium is to increase endometrial thickness and subsequently increase endometrial receptivity and subsequently improving implantation rate. Think estrogen as a cause and as a treatment. This is very important. In this very important table, the Canadian Society summarized the lines of treatment of thin endometrium, and you see just the green icon, the green point or dot is in front of hysteroscopy. The only beneficial intervention in cases of thin endometrium is to subject your patient to hysteroscopy, diagnostic versus operative hysteroscopy. Other lines of treatment like estradiol and HCG and so, these are either no evidence of benefit or unclear evidence. So if we go in details for estradiol logically is a hormone for stimulation of endometrial proliferation, so it is a good line of treatment for the endometrium, but the evidence is not so strong to support its role in cases of thin endometrium. It causes spiral artery contractions and decreases oxygen tension in the functional zone and improves embryo implantation. We can use micronized estradiol or estradiol valerate. Usually we can prescribe estradiol as a single dose of 2 milligrams per day. This is quite sufficient to make blockage of the hypothalamo-pituitary-ovarian axis. No need to add GnRH analogs in the luteal phase for this line of treatment. Some authors used high dose 2 milligrams 3 times daily from day 1 to day 12, but no evidence of benefit for this line of treatment. Some used extended administration of estradiol of 16 milligram daily of estradiol valerate, which means 8 times the regular dose of estradiol from day 3 to day 9 before stimulation, and also no evidence of benefit. Some used estrogen vaginally, which is 25 milligrams daily from day 4 to day 15 in the clomiphene citrate induced cycles in some studies with no evidence of benefit. Some used combination of oral and vaginal estradiol to improve the result and to increase absorption of estradiol, aiming at improving endometrial thickness, but no evidence of benefit. All studies used ethinyl estradiol, dose 50 microgram to 150 microgram daily from day 7 to 10 of the cycle to improve endometrial thickness. HCG can be used to after estrogen administration. We can inject daily HCG at a dose of 150 international units for 7 days to improve the endometrial receptivity, but no evidence of benefit. Granulocyte colon stimulation factor injection to increase endometrial thickness, also no unclear evidence. The moda of PRP in medicine is extending and expanding, and this line of treatment is used in different specialties. Of course, thin endometrium is one of these indications, and some use inject PRP underneath the endometrium to stimulate proliferation of the endometrium, particularly in cases with intrauterine synechia and marginal synechia, which means synechia surrounding the uterus without central adhesions, with some results in scarce studies, but unfortunately there is no recommendation by different societies, including the Canadian Society, no unclear effect so far. The hysteroscopy has a central role in evaluation of any case of thin endometrium. You should ask your patient to have hysteroscopy. Hysteroscopy is a good diagnostic tool and at the same time can be a good therapeutic tool of thin endometrium. How? You should evaluate the pattern of the endometrium, the vasculature of the endometrium. If you can see some adhesions, fine adhesions that cannot be seen by transvaginal sonography or even three-dimensional sonography, this is a good and crucial rule of hysteroscopy. And don't forget that it is the only documented beneficial intervention in cases of thin endometrium as recommended by some societies. And here the endometrium is seen in inflammatory cases. You can see endometritis, you can see abnormal vasculature, you can see gland openings, and so all these issues can be seen by hysteroscopy. You can, in this short video, you can see the endometrium is very pale, the vasculature is diminished, and no intrauterine synechia explaining this thin endometrium, but pallor is common. Sometimes you can see some petechiae informing inflammation of the endometrium, and you can see here the tubal ostium and the intratubal part of the ostium. This is can be seen by hysteroscopy. So in conclusion, the endometrium has a crucial role in infertility as an indirect indicator of the endometrial receptivity, and it has a prognostic role in the pregnancy rate in cases of infertility. Patients with endometrial thickness less than 8 mm should be counseled that they may have a negative impact on pregnancy rate and live birth rate if they are subjected to fresh or frozen IVF cycles. Birth rate. Thin endometrium, if you see it by ultrasonography, you have to think estrogen as a cause and put estrogen as a line of treatment in your mind. Is very important despite poor evidence of its role in cases of thin endometrium. The hysteroscopy has a central role of evaluation of thin endometrium and should have a priority. Freeze-all technique for cases of IVF ICSI is a good option until improvement of the endometrial thickness and endometrial receptivity. When to ask for endometrial receptivity testing, these tests are complicated, costly, and asked when the treatment to increase endometrial growth fail and is not a routine testing. The most important issue in this topic that good counseling is very important. In the meantime, honest and balanced information provided to our patients is the best we can offer. If you like this lecture, please press on the like icon and don't forget to press on the notification and subscribe icons as well. Thank you very much.